Hey everybody, I'm Chris Flanagan. Welcome to What's Going Around. Each week we talk to doctors around the DMV to see what they're seeing, what's happening, and what's going on. And today I'm really thrilled to be joined by one of the world's most renowned colorectal surgeons, and we are proud to say he is now in the DMV. Dr. Stephen Wexner, he is a colorectal surgeon at MedStar Georgetown University Hospital. Dr. Wexner, thank you for joining us, and it's really an honor for us to have you.
Well, thank you very much, Chris. And it's an honor to be in the DMV. I'm really, really excited about being able to work with the doctors, the referring physicians, and the patients, the other healthcare providers in the DMV.
Yeah, welcome. And that was kind of the Cliff Notes title for you, but really, Dr. Wexner, you are the physician, executive director, and system chief of colorectal surgery at MedStar Georgetown University Hospital, and you just started in November, so you're very new on board.
Yeah, essentially, I just began November 1st at MedStar Georgetown, although it's been quite a while in getting things ready. So I've had a lot of time to get up and running and to learn the members of the team and figure out how we can best help our citizens and patients.
And you came from the Cleveland Clinic, one of the the top medical facilities in the world.
Yes, I'm very proud to say that I joined the Cleveland Clinic. I signed on in October 1987 when Cleveland Clinic was opening in Florida. I was one of the first 26 doctors to build the facility, and I put a lot of time and effort into it. When I began, we had no residents or fellows. When I left, we had one of the largest ACGME accredited commission for graduation medical education programs in the US. I had trained over 150 clinical and over 600 research fellows who are now in leadership positions around the entire globe. Helped build a medical staff that started at 26 and is now something over, I should think, 500 or so. Been huge growth in the program there. We ended up getting recognized in many media, including the U.S. News and World Report, and really had a good time. And essentially, I'm going to apply the lessons learned and be able to repeat the good things and maybe not repeat some things which weren't quite as good at accelerated pathway. My aim is to put an even better program together at MedStar Georgetown.
Yeah, well, we are lucky to have you here in the DC area. We're looking forward to working with you. Um, I saw an article in the Washington Post recently, and it's saying how there's so many younger adults under the age of 50 in the United States now being diagnosed with cancer. Why are we seeing that? Why is there such a prevalence now of younger adults being diagnosed?
Yeah, firstly, thank you, Chris, for the warm welcome and the compliment. And secondly, I wish I knew an answer. I wish there was one simple, straightforward answer because I'd love a trip to Scandinavia for a Nobel Prize, but I don't think any of us are quite near that point. I think we do know number one, that it's happening. And the first way to treat a problem is to recognize it exists, and we do recognize it exists. Second is to delve into the cause of the problem. And it seems to be multifactorial. It seems to be somewhat of a genetic drift. It seems to be familial, related to what goes on in one families, but more and more we're seeing sporadic cases, which means it has to be something else. And then that points to diet, to environment, to lifestyle, to things ingested, whether those things that people are taking are harmful or helpful for colorectal cancer. So it's being approached by many, many researchers in lots of different areas as to why it may happen. The good news is, at least for the inherited variety, we've learned a lot more, but it's unfortunately the minority of cases. We've learned a lot more over the last few years over the exact genetic mutation. We can be far less invasive in our testing and procedures in that population. We have not nearly made that degree of progress in the non-inherited varieties.
And Dr. Wexner, when did you start seeing uh, really a wave of more younger adults starting being diagnosed with cancer? So the last 10 years, last 20 years, when did you, as in your practice, start seeing it?
I would say it's at least 20 years, if not more. The difference is that it used to be very unusual. When I had a patient who would come in, and I remember, for example, a nice young lady, yes, in her upper teens, who was the daughter of a healthcare provider, who came in with the father very concerned how this had happened, and yeah, that his daughter had had rectal bleeding a lot, and everybody ascribed it to hemorrhoids, including that particular doctor and the gastroenterologist and the gynecologist and everyone else. So, yeah, somebody in their late teens, and they had cancer. That was pretty unusual at the time, somewhere between 20 and 30 years ago. But as time has gone on, those cases have sadly become much, much more frequent and are occupying a bigger percentage of the cases being seen. The the issue is recognition, and I think early on everybody, probably including myself, said, "Oh, here's an unfortunate young patient who really shouldn't have this problem at this time." Now we say this is one of many unfortunate young patients who shouldn't have this problem at this time. We've expanded our genetic programs, our screening programs. We have people who's essentially they're genetic sleuths. They will sit down and work on the family tree, make sure every other first degree family member is screened, give instructions and schedules for frequency and types of screening for other members of the family who are clearly going to be potentially at risk. So we've been more sophisticated in trying to nip it in the bud, as you will, but we still can't just pick somebody on the street and say, if you come out of this test, we'll know you're going to have colon cancer with 100% certainty.
And Dr. Wexner, is this something we're seeing specifically here in the United States, or is this a global issue? Are we seeing younger people all over the world being diagnosed with cancer at a young age?
Sadly, Chris, it's become a global phenomenon. And as I go to different meetings here as we speak today, I'm giving the keynote address at the Taiwanese Society of Colorectal Surgeons. One of my alumni is the president of that society and also superintendent of one of the major hospitals, invited me to give a keynote address. I heard the same thing here at this meeting
Hmm.
yesterday, recently being at other meetings in the UK, British Association of Surgical Oncology, in meetings in Europe, Latin America, everywhere it's increasing. We're seeing two different types of increase. We're seeing more colorectal cancers in countries in which colorectal cancer wasn't usually a common cancer, and those tend to be the World Bank tier 3, 4, 5 countries. Then in the countries that are already developed, tier 1, tier 2 countries, we're seeing more colorectal cancer in younger patients. In all 5 of the World Bank tier countries, we're seeing an increase in young people. So it's like a double whammy in the low and middle income countries and the increased prevalence in younger people in the developed countries, if you will. So it is really global.
And when you're treating these younger adults, is it different treating somebody younger than an older patient when it comes to different sorts and different types of cancers?
Yeah, great point, Chris. Firstly, it's different for diagnosis because when you're looking somebody in the eye who's 70 and say you may have an issue here, we need to do a colonoscopy and a CAT scan, whatever, they kind of say, okay, sure, I hope it's nothing, but they kind of understand that at that age things happen. When you're sitting there with a 25-year-old, let's say, healthy woman, unmarried, healthy guy, athlete, whatever, often with both of their parents, maybe a sibling, and at that point, maybe a significant other, a partner, and you're saying, you need a colonoscopy because there may be an issue, and they start saying, what issue? And you say, well, it's possible that you could have and I try to go on the lighter side and say a precancerous growth or a growth or something like that. I wouldn't want to just come out and say you may have cancer till we know that's the case. But that's a very different conversation because this is something like out of the blue. Here, this person either has never seen somebody before, more likely they've seen several healthcare providers, each of whom has ascribed their bleeding to hemorrhoids or some other problem down below. The ones that are even more difficult, I think, are the ones with no symptoms. And 50 50%, half of colorectal cancers have no symptoms. So how would somebody know? They decided that I've got a little belly pain that now becomes a symptom, but by the time that symptom comes along, it may be more advanced. So the conversation is difficult because the person isn't expecting it. Number one. Number two, the conversation is difficult because the patients with symptoms may be more further advanced than the patients without symptoms. Then there's the treatment part. When you get to treatment, again, in generally speaking, older people have different expectations than younger people for what they're going to be doing after surgery. How long is the disability? Will I or will I not want to, or rather have to wear a bag, which of course nobody necessarily wants to, but again, looking at that example of somebody in their early 20s with their whole life ahead of them, who's going to be dating and finding a life partner and having kids and all of that and wanting to play, intensive sports may potentially be different than the patient who is in their 70s or 80s who is retired and doesn't travel much. So now there's a part of the treatment plan that has to adapt to that lifestyle and those expectations to make sure, for example, that the patient is able to get the best possible quality of life for a patient that age. Obviously, we want everyone to have the best quality of life. There's no question whatsoever. But the patient's expectations based on their baseline activity may be different. So we have to think about surgical techniques that are going to preserve the integrity of their lifestyle and fulfill their demands, as well as know that whatever we do is going to be there for a very long time. An example is operating in a woman of childbearing age. We want to minimize the risk of infertility. We want to ensure that woman has the choice later on to get pregnant if that's the desire. If we have a patient who has a view on professional sports, and I've taken care of many people in professional sports, we want to make sure whatever we do gets them back as quickly as possible with the least possible compromise in what they need to do in what they physically need to do, right? So there's a variety of considerations, certainly. And then when we have young people, we have to ask, as I mentioned earlier, that genetic sleuthing. We need to say, we need to chat with your brothers and sisters. We need to create a family tree. We need to figure out what other tests and need to be done. So it's not in isolation. It becomes a so-called family affair, right? Everybody's got to get involved, including the parents who may be at risk. And the first person in the family recognized to have the problem is sadly not the parent, but the child. And now we have to work backwards and tell the parents, you're at risk. And I've certainly had situations like that where the child is presented first, and then we find out that the parent, who was the progenitor, let's say, has an issue.
So obviously, genetics and family history can play a role. What about environmental factors? How much has that changed in the last decade or two when you're making a diagnosis in a young patient?
Yeah, great point, Chris. Diet and environment are a bit more elusive because they're not as easy to test, in a laboratory somewhere or under a microscope. But they're certainly there. And historically, as I mentioned earlier, with the increasing rates of colorectal cancer in the low and middle income countries, many people ascribe that lower level to the diet and to the environment. They're eating less processed foods. They're eating less saturated fats, perhaps. They may have as a baseline more exercise for the simple reason they may be walking more or bicycling more as a mode of transportation. And then the environment may be different. They may not have the same chemicals, substances, pollutants in the air, in the water, in the food. And there's a lot of work going into that, but certainly environment plays a huge role. And you can see these genetic drifts because you can see populations where even as recently as when I started in practice, which is close to 40 years ago now, I would go to certain countries of the world, and speaking about rectal cancer was interesting for them, but they didn't have a big population of patients with rectal cancer, and now they do. And as you visit these places, you see a lot more American, if you will, or Western types of food and Western habits adopted. And they've become much more industrialized in these places. Does that have a role? It has to. I don't know exactly what that role is, but anecdotally, based on what I see as I travel around the world the last 40 years, it absolutely has a role.
Dr. Wexner, what about lowering screening ages for various cancer? Colorectal, that was lowered from 50 to 45 recently. Breast cancer for women, this really it's fluctuated multiple times. What are some of the pros and cons of screening earlier, and are there cons of early screening?
Yeah, again, a really good point. And I always like to say that one of my favorite quotes, other than from Winston Churchill, is Benjamin Franklin, that an ounce of prevention is worth more than a pound of cure. Colonoscopy is one of the few tests, perhaps the only test, that has the capability to both find a precancerous lesion and eradicate that lesion, therefore preventing the cancer ever coming on stage. Other things, breast exam, mammogram, if there's a shadow there, you biopsy it, and it may be pre-malignant, but very often it's already malignant. Sometimes it's just scar. But there's not this exact linear progression that we have with colon, where here is what's called an adenoma, which is a precancerous polyp. If we leave it in you, we know it will become a carcinoma, a cancerous growth. So if we take out that polyp, the cancer is not going to happen. That's a very linear relationship and it gives us tremendous opportunity to prevent cancer. Looking at other lesions, it's just not that straightforward. Even skin cancer, certainly not pancreatic cancers, colorectal cancer, it is. So screening has a tremendous upside of being able to actually prevent cancer. And that's the difference of screening, looking for things in somebody who doesn't have a particular reason to have those things, versus surveillance, which is following up somebody who did have a problem already, versus a targeted screening in somebody who has a risk. So let's say the first population, the person without the specific risk, other than living in the DMV or somewhere else in a developed country, eating things that they find around the fast food markets and perhaps not exercising enough and perhaps not drinking enough water and all the things we always tell patients. And in that patient, what do? There are several options to screening an asymptomatic patient, one of which it remains colonoscopy. And colonoscopy truly is the gold standard because it allows us to look and treat all of the other tests that are now available by mail and that are heavily advertised have a certain amount of what we call false positive, where the test comes back saying, yeah, there may be something there. And in fact, the patient goes through a colonoscopy and there isn't. Or what's a bit scarier is the other direction, where it's a false negative and it misses a lesion, a growth, and gives the patient a false sense of security. However, a lot of people don't want to deal with colonoscopy. Personally, I think colonoscopy is a very easy and very safe test to undergo. The worst part of it is the bowel preparation, cleaning out the bowels to have colonoscopy. And it's just plain uncomfortable. That's all. I mean, you've got to spend several hours taking a variety of substances to cleanse the bowels so that the endoscopist has a good look throughout the entire length of the colon. So to distill down, the downside is that bowel prep. It's missing a day of work, and there is cost involved, although thankfully generally covered by the various payers, and taking that time to be screened. The risk of a colonoscopy is very, very minimal. I think at this point in time, statistically, the risk of getting, if I remember correctly, the risk of getting hit by lightning is something like 1 in 10,000, and I think the risk of something serious happening from colonoscopy is less. So at least that's on a golf course in Florida. But there's there's definitely it's a very, very, very safe procedure to undergo. The upside is you could save your life. screening colonoscopy saves lives. So if you say, okay, I'm going to deal with this awful bowel preparation, many people do think it's awful. I'm going to find a day to take off of work. I'm going to accept that there is a very, very, very small risk of a problem like bleeding or putting a hole in the colon, which is really close to zero these days. And guess what? I'm going to find out that I have a small growth, which I'm going to prevent becoming a cancer. Or better yet, I'm going to find out there's nothing going on in my colon at all, and I can wait 5 to 10 years until I go through this procedure again and have peace of mind. And if you're, then contemplating where does that go from there? Well, if I have a lesion, one of my first degree relatives might have it. But
Right.
if I don't have a lesion, now I know my family has a higher probability of being safe. So I think the pros way outweigh the cons.
Absolutely. It's worth taking that day off from work and the prep. Definitely. Dr. Wexner, this has been just a fabulous conversation. I wish we could go an hour, but I know, you're in Taipei right now. You've got a big conference, and we appreciate you getting up at 6 in the morning, your time, to spend a few minutes with us. It's so valuable, and we really appreciate you lending your expertise and insight with us here. Thank you very much.
Thank you, Chris. It's been a pleasure, and I hope we get to chat again in the future. And I hope that people listening, watching this program will avail themselves of the opportunity to help themselves prevent colon cancer.
Absolutely. And welcome to the DMV.
Thank you.
You bet. Thank you.